What we do in our specific work that is related to radiotherapy, first of all, we do a very comprehensive needs assessment and what we call impact. This helps the ministers of health to actually analyze the burden of cancer and then focus on something. And in many countries, this has helped them to see why they have to focus on cervical cancer or breast cancer or some of the prevalent men or women cancers. Second thing, we have developed a number of pilot projects to show also how can we work with others, how can the synergies that the different organizations, different partners can bring to this program to make it successful. And Ghana is one of those pilot projects, and we are very pleased with the results there. Third area that we are focusing on education and training, we have established and launched already a virtual university for cancer control in Africa, and we are hoping to extend it to Asia and other parts. This is a very extensive collaborative work, and it is not trying to create new curricula, or this is based on existing curricula that is developed and approved professionally. We are bringing that all together in all areas of cancer control and enabling countries to actually have, without sending people outside, to do continuous professional development for the existing doctors and for the new specialists to actually do the training. The fourth area we have started this year, we have established an advisory group to look at technologies. How can we make technologies more suitable, more appropriate, and more accessible to low and middle income countries? That includes radiotherapy, linear accelerators, and all the diagnostic equipment. We are working with 18 manufacturers and 12 representatives from developing countries who have basically real experience using the technologies. And the idea is to eventually help make this, bring the price to 1/5 of what is today for delivery of one complete system. The future, we are hoping to have a global alliance around this and bring more funding. And I think this is already seems to be much brighter, the future, especially since the rain has stopped today and we have some sunshine. So what our experience shows in the past 5 years. Screening is absolutely essential for this cervical and breast cancer. We're doing that in Albania, Ghana, Nicaragua, Tanzania, Vietnam. So early detection already showing good results, and they have included in their programs. Of course, expanding the radiotherapy facilities is one essential component of this, and this is already in a number of countries moving forward, and we have received donor support for it. This is very important. For example, for Ghana, we have raised $14 million to expansion 3 radiotherapy centers based on the analysis we made and based on the detailed assessment. So that shows that if you go to the banks, development banks and donors with good projects and ideas, you actually can even sell cancer treatment. Palliative care for the last stage is absolutely essential. Also, this is also lots of programs are in place, and I think we are moving forward. Now coming to the second part of the presentation, that is Dr. Camacho's part. This is a study he made, is a personal study on breast cancer, and trying to basically see whether there was a difference between cobalt and linear accelerator. This first slide shows basically the correspondence between the tumor size and the extension of the disease to the regional lymph nodes. And as you can see, the last one, as also Dr. Badve said, this is the reality, the over 5 centimeter size. That is what we are talking about. And there is also the problem of drastic surgery needed, but whether you are using cobalt or using linear accelerator, the result, the sequel is the same. You can see around the neck in both cases. So basically that is, and this no matter what sort of radiotherapy machine is used. He tried then to have 2 cases of a study using both linear accelerator and radiotherapy, one with conservative surgery and the other one with mastectomy and then radiation. And this case A and case B, try to see. And here, this is the first case with the LINAC. The green is the areas that the heart will be affected. The red is where the lung would be affected, radiation. And the blue is radiation around the breast itself. And you can see the dose distribution. Basically, the lower green and red are where the heart and the lung will be affected. This is for the linear accelerator. Next one is with the cobalt. You can see the blue line already effect coming lower. There is some dispersion, but it is not too different from the linear accelerator. And the distribution for the cobalt is a slightly higher dose for the lung and heart region. In case B, when there was mastectomy performed, again the result for, this is the study for the linear accelerator. With the dose distribution, you can see lower part in blue and green, and that is with the case of cobalt. Again, slightly more in the region near the heart can be seen. And again, the dose distribution. So what is the conclusion of his study? The teletherapy machine itself alone will not work. What is important is the other also elements that we need. We need a proper simulator. We need treatment planning system. All the other components which, sorry, it has to go back. Where does it go back? So those other components, plus a quality assurance system, these will make the result fruitful, and you will have positive results. And that is what we would recommend. At the end of the day, cobalt still is a good option for low-resource countries. The problem is that the cobalt-producing companies and also the radiotherapy companies have tried to make this much more complicated by introducing computer system, making it too electronic, and we have lots of problems with the current cobalt machines in developing countries. We have, for example, delivered last year to Nicaragua, to Tanzania and Albania, 3 countries with different levels. And in all the 3, we have similar problems with the table, with the electronics. And we have complained with the manufacturer that it actually makes no sense to make this so complicated, while the basic need that we have is a simple, homogeneous radiotherapy machine to do the job, especially for the most common cancer of interest. So if we want to summarize the characteristics of the cobalt-60 to be low investment, low cost maintenance, and robustness and reliability are unfortunately being lost because of the manufacturer's approaches. And as I said, sorry, why is it moving itself? And we are trying to work, as I said, with the manufacturers to improve that. So at the end of the day, there may be accelerators available soon in the next maybe 5 years that are equal to cobalt and can do the job, and cobalt may be replaced. The other problem with the cobalt is these days the question of security. There is a lot of pressure not to distribute radioactive sources and to watch them. That has created a lot of difficulties for the IAEA, although we have a special division taking care of the security and training the personnel in different radiotherapy centers, but we cannot put a policeman in front of every hospital and checking the patient. That would be the last thing anyone wants to do. So we are hoping that be able to help the existing cobalts, that is around 2,700 cobalts are existing in low and middle income countries. Most of them are older than 10 years, but they are working very well. So this is the hope that they could produce results that we can then take from there and for the next generation of machines. Thank you very much for your attention.
Thank you very much, Dr. Samiei, and this nice introduction again to PACT. It's now my pleasure to introduce my co-moderator, Dr. Bob Carlson. Bob needs no introduction. He's professor of medicine at Stanford. He's chair of the breast NCCN guidelines and a pioneer of the Breast Health Global Initiative.